Hi everyone, I myself Dr. Lukendra Yadav, discussing about the pediatric oncological emergency and the topic is hyperleukocytosis. And the term itself implies hyper means too much, leukocytosis means leukocyte in the peripheral blood, that is total leukocyte got more than 1 lakh per millimeter cube is called hyperleukocytosis. Hyperleukocytosis is the most commonly seen in case of acute myeloid leukemia and acute lymphoblastic leukemia, that is T cell ALL. And it is most commonly seen in acute myeloid leukemia because the myeloblasts are large in size than the lymphoblast, and so the count mostly enlarged in case of acute myeloid leukemia. And the presentation is very severe because it can cause death within hours to days, because when there are large number of leukocyte in the peripheral blood smear, and the immature leukocyte count causes stick to the endothelium of the blood vessel, and it sluggish the circulation. It blocks the narrow arteries. It blocks the circulation, causing the infarction, hemorrhage. So the death can cause immediate if we cannot control the hyperleukocytosis symptom. And so the most common cause is mental stress. Most common clinical feature is mental status disturbances that may cause to headaches, blurring of vision, seizure, altered mental status, stroke-like presentation. And also in case if the infiltration is occurred in the case of the pulmonary artery involvement, then there is dyspnea, cyanosis, fast breathing, hypoxia, acidosis may cause. And in case of GIT, there may be GIT bleed or bleeding from the any other site of the organs. And most common cause of death is CNS hemorrhage and thrombosis. And pulmonary leukocytosis leads to metabolic derangement by tumor lysis, and the most common involvement organ is lungs and brain. And so we have to do for the diagnosis of hyperleukocytosis. First of all, we have to send CBC, chest X-ray, potassium, calcium, phosphate, uric acid, creatinine, LDH, coagulation profile, and we have to see immunoblast morphology in PBS, and immunophenotyping should be done for the peripheral blood smear, and bone marrow examination should be done to send blast cell to see blast cell or immunohistochemistry. And also we have to do fundus examination to rule out papilledema, any retinal hemorrhage or leukostasis present or not. And also we have to do CT scan of the chest and head to see that any hemorrhage or any pulmonary involvement occurs or not in case of by the tumor cells. And also the presentation may be acute or chronic, and the acute presentation may come without the prior awareness, because when the patient comes with hyperleukocytosis, they don't know either the patient has cancer or not. And the last presentation may be the hyperleukocytosis, which can cause death within 24 hours to 1 to 2 days. And so our treatment is hydration 2 to 4 times. Normal maintenance fluid should be increased up to 2 to 4 times so that the tumor cells can extract from the urine, and patient may relieve the symptom. Also the urine should be alkalinized by sodium bicarbonate, because the acidosis, it can cause the acidosis part. And also the allopurinol should be 8. The dose is 250 to 300 mg per meter square per day in 3 divided dose. And also prophylactic rash can be given, rash barricades. And also platelet count should be more than, we have to maintain platelet count more than 20,000 to decrease the risk of bleeding. And don't give PRBC, because it may increase the leukocyte count. So after discussing this, it may be helpful, I think. And thank you everyone.